morning, everybody. Happy Tuesday. Beautiful out again, beautiful weekend. I hope everyone got outside and enjoyed the sunshine. It's really nice. This morning, my job is to talk to you about insulins and anti-diabetics. And this, I will say, is going to be a field that is going to be, the landscape is really going to change in these drugs in the next couple of years. And I'll try to point to you where things are going to be going. But you as practitioners are going to see, especially by the time you graduate, there are going to be some new drug classes that are going to be on the market, I predict, that you'll have an opportunity to use, which will really save lives. I mean, are going to make big differences in animals that we're trying to treat for diabetes. I am going to go through, again, the insulins and anti-diabetics. I don't know a good way to present this to you except by giving you the information. I think for most of you, I will say I lecture on this at many CE meetings, and this is like one of the most requested topics I get to lecture on because I think people find it so confusing. I will try to break things down for you. I think it's difficult a little bit because you don't really have a context in which you're using these drugs. But if we talk about anything and any of you have questions or you want to bring up a case that you might have seen in a practice that you've worked at, let's talk about it because I think it might make it relevant for everyone else. Okay, so I'm going to hopefully convince you today that you need to know this and why, because it's going to be a really common disease, so hopefully I can convince you of that. We're going to talk, as always, a little bit about physiology to kind of focus our thoughts in on diabetes and the disease that we're trying to treat, and then we're going to talk about the drugs that we're going to use to treat them. Okay, these are common. Diabetes is really common in dogs. How do you know this dog has diabetes mellitus? Yeah, he's got cataracts. That's absolutely right. Ooh, let's see what my pointer looks like today. I forgot. I don't think I changed it. Oh, it's boring. Sorry. But yeah, look at that. He's got cataracts. This is an incredibly old picture. This dog's name was Widget. He is long gone over the Rainbow Bridge. But you can actually even see the little sulci in here, the little fissures in his cataracts. Okay, so cataracts very common in dogs that have diabetes mellitus. And it's also a common disease in cats. And what might make you think this cat might have diabetes mellitus? Because it's fat, okay? So cats very commonly get diabetes mellitus as well. Again, it's a very common disease that you're going to see. For any of you that decide that you're going to go into zoological medicine, we see it in primates as well. When I used to work in Philadelphia, there was this is not him, but there was an orangutan at the Philadelphia Zoo who was diabetic, and they trained him to stick his arm out to get his insulin injection. So you will see that as well. So remember that in your pancreas, remember most of your pancreas is devoted to exocrine activity, right? It helps you digest your food. But there's little parts of it throughout the pancreas. They're called the islets of Langerhans, and they contain all the endocrine activity for the pancreas. And the major cells in the islet of Langerhans are beta cells, and they secrete insulin. So those are the ones that we worry about. And when we talk about beta cells, we're talking about the cells that are secreting insulin. Insulin was discovered in 1922 by Banting and Best. They actually used dogs to help them discover this. Before this time, juvenile type diabetes was really a serious disease and most people died from it. But they actually used a pancreas extract to treat a diabetic dog successfully. And so this led to the discovery of insulin. They got a Nobel Prize for that. Insulin, remember, is a hormone of abundance. It helps you capture the calories that you eat. So if you don't have enough insulin, you don't get any of the calories that you eat to any of the cells that need it, mostly your muscle, your liver, and your fat cells, but it doesn't help you utilize what you're eating. So it's a hormone of abundance. Insulin is a little protein, And this is the thing that always amazes me, because insulin is really complicated. It is, because there's so many types, and we'll talk about why that is. But it is a tiny little protein. Look at it. Here it is in all of its glory. It's small, it's little, it's got a pretty simple shape. You've just got two chains. They're hooked together by some disulfide bonds, and that's really it. It is highly conserved. So if you look at the domestic species that are the farthest apart, it would be the cat and the human. There's only 4 amino acids difference. So it's very highly conserved, which is why we can use human proteins to treat diseases in our veterinary species. Okay, insulin lives as a hexamer. Oh, look, my little C got taken away from the zinc. That's supposed to be zinc in the middle there. There's the C down there. But it lives in this hexamer. This is what it looks like around a zinc molecule. Zinc is a stabilizing molecule for insulin. You'll notice that when we talk about some of the precipitated insulins on the market, most of the time they're precipitated with some kind of a zinc molecule because it helps stabilize it. But this is what insulin looks like when it's released and it runs around your body, and it actually has to dissociate into a monomer in order to become active. And the reason I'm telling you this is because there are mutated insulins, we'll talk about briefly, that are available, mostly used in human medicine, that are mutated so that they are stable in this monomeric form like this. And that means that they work even quicker than like a regular insulin, which then is running around in this form because this doesn't have to break down. So this is your active part. Okay. Insulin works quickly and it goes away quickly. It's a peptide hormone, like parathyroid hormone. So it's going to travel, it can travel through your bloodstream unbound because it's a peptide hormone, so it's soluble. It goes to a cell surface receptor, the insulin receptor, and it activates that cell really quickly. So it's a quick on and off, and it's got a very short plasma half-life. Because in the plasma, there are actually insulinases that live in the plasma that help break down the insulin that's not bound right away. And even if you didn't have them, it would go away pretty quickly. So the half-life normally is about 8 minutes, and all the insulin you secrete that is not bound to a cell surface receptor is gone in 15 minutes. So it works really, really quickly. Your major cells that utilize insulin are the liver and the muscle and also the fat. The kidney is another way that you actually can get rid of insulin as well. But what I really want you to remember is that insulin works quickly, goes away quickly, and this is why it is so confusing. It is our pharmacologic ability to make repository forms of insulin that make all the different types of insulin, and that's where insulin therapy gets really, really confusing. Okay, so it's a peptide hormone. I think I already said all this stuff. And so it works like any peptide hormone. Okay, so what diseases are we trying to treat? We talked about how it's common in dogs, it's common in cats. We also see it in primates as well. In dogs, we primarily see insulin-dependent disease. So they get the juvenile type diabetes mellitus, very similar to what we see in children that get diabetes mellitus. This is also called type 1 diabetes mellitus, and it's we do see it rarely in cats, but for the most part, dogs get that. Cats get non-insulin dependent or type 2 diabetes mellitus, and this is the type of diabetes mellitus that's on the rise in humans because of changes in our lifestyles. We've become more sedentary, we've become fatter, and all of those things serve to make us diabetic. So cats, as they live our lifestyles with us, they're pretty happy to sit next to you and sleep, and they're pretty happy to snack. So they have adopted what we've done to ourselves. They've become less active and heavier, and that has predisposed them to getting diabetes or non-insulin dependent diabetes mellitus. Dogs can get it too, but it's much less common. So for the most part, dogs are absolutely insulin dependent. Cats are non-insulin dependent, which means that they are more of an insulin resistance phenomenon, which is why cats can go into remission. Okay, so when you're talking about insulin therapy, and again, the reason that insulin it's so complicated is there's a gazillion types on the market, and that's what makes it so complicated for us to actually pick an insulin. And what I'm going to try to do is tell you the components that go into making an insulin. And again, the reason it is so complicated and the reason there's so many types is because we're trying to make a form of insulin so that you don't have to walk around with a continuous drip in you all the time to get insulin. We're making it into a repository form, and there are many mechanisms to do that, which is why we have so many different insulins on the market. But I'll try to break them down for you and at least tell you what I think is important in terms of you choosing an insulin that you want to use. So the things that I think about when I'm talking about insulin or thinking about insulin are the source, like where it comes from, the type, or what we've done to it to make it a repository form and how that's going to behave in the species that I'm treating with insulin, and then the concentration. All right, so with the source, you've got three different sources that we have of insulins that are on the market. You can have a human recombinant, meaning that you've taken the human DNA sequence, you've put it in bacteria, that has spit out insulin, you purify it, and you use it. And the ones that we use in veterinary medicine most commonly that are human recombinant insulins are regular insulin, like Novolin or Humulin R, NPH insulin, like Novolin or Humulin N, and also PZI insulin, like Prozinc, okay? Another thing that you can do is you can mutate the insulin. And these are most of the insulins that have been recently generated on the market. Most of them are used in human medicine. They take the human DNA sequence, they mutate it in some way to give it a pharmacologic advantage, and then utilize that as well. And some of the ones that we use in veterinary medicine that are human mutated insulins are glargine, and that would include Lantus and also 2-JO, and I'll talk about that a little bit more. Detamir or Levemir. There's another one, Degludec or Tresiba is another one that's mutated, and Lispro and Aspart, which are short-acting insulins. The other source that's out there, and it's the only animal source left, is Vetsolin. So that is from pork insulin. The idea behind that is that canine insulin has the same DNA sequence as porcine insulin, so the idea was that if the DNA sequences were the same, that it would work better. I don't think that that's probably that important because we use a lot of insulins that are based on the human DNA sequence that work just fine. But that is the only animal source of insulin left on the market. Okay, the type of insulin, as I said before, is what makes it complicated. And it's what we've done, well, not me, but what pharmacologists have done to it to make it into a repository form so you don't have to walk around with a continuous rate infusion drip going all the time. You can either precipitate them with components to make them last longer, or you can mutate them, okay? So when we're talking about types of insulin, we have the ones that we've made into a repository form, but we also have ones that we haven't really done a whole lot to. And these are going to be ones that we're going to use in an emergency situation. So these are rapid-acting insulins. Regular insulin is the one that most of you are probably familiar with. Any of you that have worked in a practice environment, you've probably seen regular insulin on the shelf. It's what we use when an animal comes in and they're a ketoacidotic diabetic or a hyperosmolar diabetic. And the advantage to regular insulin is that you can give it not only intravenously, but also intramuscularly and subcutaneously. So you can give it all of those ways. Works quickly, goes away quickly. Remember, it's in that hexameric form. Two mutated insulins that are out there that are used a lot in human medicine. So these would be insulins Aspart and Lispro, which are mutated so that they exist in that monomeric form that we talked about before. And they're used in human medicine as kind of a basal bolus thing. So people that are diabetic will take a basal insulin, and then right after they eat, they'll give themselves an injection of a very short-acting insulin, and they use Lispro or Aspart. These have been used in veterinary medicine, not a huge amount, so I don't think there's something, I want you to know that they're out there because your owners will ask you about them, but I don't know that there's a huge use for them right now in veterinary medicine. They're expensive. And these would be things you would use in an emergency situation. The long-acting insulins are where things get confusing because those are going to be the insulins that, again, there's going to be a million types out there because of the things that we've done to them to make them last longer. So you can have and these are the ones that are, again, in a repository form. So you can have them be precipitated. These are the insulins that are cloudy. So who's used a cloudy insulin? Okay, they're pretty common. Most veterinarians are using products that are precipitated. So the common ones would be Lente or Vetsolin, Prozinc or PZI or NPH insulins. You look at them, they're cloudy. You have to mix them before you use them. The NPH and Prozinc, you roll gently to mix. With Vetsolin, because it's a mixture of semi-lente and ultra-lente insulins, you have to shake it really hard before you use it. You can also mutate them, as I said before. These are insulins. They're mostly used in human medicine, but we use a lot of glargine and also detamir in veterinary medicine. And these have been mutated to give them different properties that we want them to have. So for instance, glargine, which the U100 or the less concentrated form is Lantus. How many people have used that in cats? Okay, so it's a common insulin that a lot of people use in cats. And there's also a U300, which I'm going to tell you about, which is a very nice rescue insulin in cats called Toujeo. It's more concentrated. But these are mutated so that they're stable at a pH of 5. So it's clear when you look at it in the bottle. But once it goes under the skin and it sees a pH of 7, it will actually crystallize out, and then the insulin will kind of fall off of that crystal over time, again making it a repository form. Another strategy is what's used in detamir, and detamir is mutated so it has a carbohydrate moiety on there that binds to albumin under the skin, and then it's released. The insulin then is released slowly. The insulin molecules come off of that complex really slowly. And degludec or Tresiba uses a different mechanism, and basically it's synthesized as a hetemer, and then when it goes under the skin, it makes a huge complex, which again, the insulin molecules come off slowly. There's nothing inherently different about any of these mechanisms except what works best in the animal or person that you're using them in. So diabetes is big, big money. It is one of the, and actually your generation, it said that your generation is going to live, have a shorter lifespan, a lot of because of diabetes and obesity related diseases. And this is one of them. It is big business. So pharmaceutical companies, it is in their best interest to come up with an insulin that they think is better so that they can get a better market share on treating diabetes. So that's why there are all these different insulins out there. Okay, the other thing that you have to think about is concentration. Insulin syringes are measured in units, not in concentration. And you have to match the insulin syringes up with the type of insulin that you're using. This is almost always an issue. It's not so much of an issue in human medicine anymore because most people are using insulins that are in pens. So you don't have to figure that out. You just set the pen for whatever unit you want. But in veterinary medicine, we're still using a lot of pulling it up in the syringes and injecting it. And if you don't use the right syringes with the right insulin, you will give the wrong dose. U100 insulins are almost always people insulins or human insulins, which we use in veterinary medicine, that means there are 100 units per mil, and you need to use an insulin syringe. It says U100 on it. Okay, and this is a list of some of the ones that we use in veterinary medicine that are U100s. U40 are less concentrated. There's exclusively veterinary insulins now. There aren't human insulins on the market like this anymore. It's nice as a veterinarian to use a U40 because you can make smaller increments and changes because it's less concentrated. But you have to use U40 syringes. Most human pharmacists do not know that U40 insulins exist. So if your client goes to get insulin syringes from the pharmacist, they will come back with U100 syringes. So you have to be really careful about that because they'll come in and you're like, why isn't this working? And all of a sudden you find out they're using the wrong thing. So and these are some of the ones, the U40 syringes, these are licensed for use in veterinary medicine, PZI or Prozing, Lente or Vetselin. These are the two veterinary licensed insulins out there. This is one of the reasons that I have owners, like when I'm rechecking them with when they come back in for their diabetes rechecks, I make them bring in the insulin that they're using and the syringes, because I cannot tell you how many times people get things confused. They think they know what they're doing and they don't. Now, can you use a U40 or a U100 syringe with a U40 insulin? You can, but it requires math. And that never goes, I'm telling you, it never goes well. So I know some people will try to do things as cheaply as they possibly can, but it is worth it if they just get the right syringes to go with the right insulin. Okay, so most common that you're gonna have to deal with is U100 versus U40. However, in human medicine, people have gotten bigger, right? And so they don't want to give themselves tons of insulin. So now we have more concentrated insulins on the market. We have up to U500 insulins that are on market now, and some of the U200s and 300s I've listed up here. Glargine or Toujeo is a U300 insulin, and it is going to be, I'm going to tell you later, it's going to be a nice rescue insulin in cats. It works in some cats that you can't get anything else to work in, but you don't have to worry about the concentrations as much because it comes in a pen. So you're going to be using a pen with it because you can't really measure that out anyway. Okay, dosing convenience is something that you need to think about. There are some people that cannot, and honestly, it's amazing to me it hasn't taken off more in veterinary medicine, but it really hasn't. It is, in human medicine, the dosing pens were huge. Like, it made a big difference for human diabetics, getting a dosing pen. In veterinary medicine, so there's dosing pens available for all the human insulins. You can get them for the Lantus and Denomir, and then for all the human insulins available, they have a dosing pen. It is interesting to me that there's only one dosing pen available for veterinary medicine. It's the Vet Pen for Vetselin, and it is not highly used. When I lecture to practitioners and I'll say, how many people use the Vet Pen? No one does, and I'm shocked about that because it's very convenient to have a pen where you just set the units on it. Now, the issues with the human dosing pens are when you put the cartridge in there, you break sterility, and there's also air that gets in there, so they don't last as long if you use the pens with the cartridges. But Vetselin lasts, it's stable for like 6 months in the pen, so there isn't even that much of a problem with that. So again, I'm surprised that more people haven't used it, but it is not very popular. Another thing to think about is FDA approval. We in this country, which is not true in many countries, we are allowed to use things off-label here. In many European countries, and even in some Asian countries, you either don't have non-veterinary drugs available, or if you are a veterinarian, you have to use a veterinary product first, prove that it doesn't work before you can go ahead and use a human product. We here use human products off-label all the time, and as far as I know, there has not been a lawsuit about that, but there will be. You wait. And so if you use something that's licensed for use in veterinary medicine, legally you're protected. Also, the nice thing about using something that's licensed for use in veterinary medicine is if you have a problem with it, you can call the company and they have to talk to you, but they want to talk to you because they want to find out what the problems are. And they have to report problems to the FDA. So the 2 veterinary approved insulins out there are Prozinc, made by Boehringer Ingelheim, and that's licensed for use in the dog and the cat, and also Vetsolin, which is made by Merck, and that is also licensed for use in the dog and the cat. Okay. I know this is a lot, and even as every time I present this, I try to think of an easier way to present this, and I don't know how to do that for y'all because you don't have experience in treating these diseases yet. So I'm going to go through a couple of, this year I decided to change this, and I'm going to go through a couple of what do you pick when. All right. So what are you going to pick when you have an emergency situation? You're in the clinic, usually it's like 4 o'clock in the afternoon, you're usually hungry because you didn't eat lunch, and you didn't eat lunch because you get to go out to dinner that night and you're saving your appetite, and you're like, okay, I just want to get the hell out of here, go home and take a shower, get ready to go out. And a diabetic ketoacidotic walks in the door. And you're thinking, oh my God, that's almost as good as a GDV walking in the door. So something comes in the door, it's an emergency situation, what are you going to pick? A ketotic animal, a ketoacidotic animal, or a hyperosmolar animal. And you're going to want to pick an insulin that you can use that's going to work quickly, go away quickly, and that you can give intramuscularly or intravenously, because those are the insulins. You can't give a subcutaneous insulin to a dehydrated animal. So you're going to want to pick something that's going to work quickly that you can give intravenously or intramuscularly. So how you can give it is really helpful. So one of the ones that's going to be the mainstay for you in practice is going to be regular insulin. I have a picture of Novolin R, but there's also Humulin R out there. Generic regular insulins work fine too. It is a U100 insulin. It works quickly. It goes away quickly. You can give it sub-Q, IM, or IV. Okay? So this is going to be on any shelf of any practice that does any kind of emergency work. You can use it intermittent IM therapy. I put this up here for you. This is in every critical care book or emergency book that's out there. There's nothing special about this dosing. But when you go into clinics here in the hospital, they like to use continuous rate infusions here. And those have been shown to work well and probably be a little bit better. But in many practice situations, it's really hard to do that. So I want you to know there's an intramuscular protocol out there that works just fine for a lot of DKAs. You won't see that used here that much, but it is used in practice. So I have this up here. The big secret here is that you want to start your IV fluids first, and the emergency people here will tell you to wait 12 hours before you start insulin. I like to start things rolling a little bit early, maybe after 4 hours of fluids, but you want to start your fluids first to get them hydrated before you start giving them insulin. Okay. The continuous rate infusion, again, you don't need to memorize these. They're in every textbook that's out there. There's no reason to memorize this. And this is just a table. It started at the University of Pennsylvania years ago. It's been mutated to many, many different protocols. What you will see is a table hanging up in the ICU or the emergency room to tell you how much to give. And this is your continuous rate infusion, giving it IV. The secret with doing these, the IM and the CRI therapy for this, is going to be that you want to bring their glucose down, but not bring it too low. If you start going below, so that's the reason that when you get below 250, like you can see this back here, when you start getting below 250, you're going to stop you're going to really slow your insulin rate down, and you're going to be starting to add in dextrose, because you don't want your blood glucose to go below 250, because when it does, remember that when you get hypoglycemic, you'll kick in with all these counter-regulatory hormones that kind of kick in and raise your blood glucose, and you want to avoid that. Okay. The monomeric insulins, the ones that are mutated to be in a monomer form, you can use as well. They've been used in veterinary medicine as a CRI. I'm going to just say they're out there. No, they're out there. I don't think there's going to be a lot of use for you to have in practice, really. Like, we just don't use them very much because they're really potent, and for the most part, we don't need to. Okay. All right. So, in an emergency situation, you're going to want to pick an insulin. You can use IV, IM, or sub-Q, because you don't want to give anything sub-Q to a dehydrated animal, right? And so basically, regular insulin is going to be your go-to. There are some protocols using glargine and blah, 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 but it's too, like, I just want you to remember to go to regular insulin. That will get you out of trouble. It's cheap, it's available. You will have it on a shelf that you'll be using. So what might you choose to pick if you have a stable animal? So it's newly diagnosed, or you're transitioning it from an emergency situation, or you're changing insulins. You are going to pick a repository type insulin, and or a long-acting insulin. And I think what I neglected to tell you, and I'm sorry about that, is that all of the long-acting insulin choices need to be given subcutaneously, which is why you can't use them in an emergency situation. Okay, so when you pick a basal insulin, and what you guys will learn as you deal with a lot of owners in chronic situations is, like, we try to pick the best therapy for our patients, but the person not to forget is the owner, because you have to get owner buy-in on everything that you do. Like, you can come up with the absolute perfect protocol for a patient, but if the owner won't do it, you can forget it. It's not going to happen. So it's really important to think sometimes about what the owner needs. So remember what our treatment objectives are in diabetics. We don't have to keep their blood glucose between 100 and 200. We just need to control their clinical signs like polyuria, polydipsia, polyphagia. We have to control neuropathies. We want them to feel good, regain their energy, and regain their muscle mass, and keep them out of the emergency room. Those are our goals. So again, don't have to worry that much about keeping their blood glucose under really tight control. So we can afford to pay attention to what the owners can and can't do. All right. The other thing, and I know this probably, I want to introduce you to this way of thinking because, again, owners are so important. And one of the issues that's come out in the last probably 5 years, starting with some really great work that came out of the Royal Veterinary College, is how difficult it is for people to own a diabetic pet, and how many lives are lost because we've created protocols that people just can't do. And in recent data that's come out, and these studies have been done all over the world now, up to 30% of pets are euthanized either at diagnosis or within the first year after diagnosis of being diabetic, which to me as an endocrinologist is incredibly frustrating. It's a disease I can diagnose easily, I can monitor it easily, and I can treat it. And yet I'm losing patients because owners just can't do what I need them to do. And if you think about your life right now, what your life is like, and think about if you have a diabetic pet. Does anybody have a diabetic pet? Okay, what's your life like?
It's very constrained. Like, I can't really go out very often at night because I have to think about my schedule. I have to go to the weekend and everything.
There you have it, right there. And that's exactly what owners say. It's lifestyle restricting, because if you're a diabetic, you can go out to dinner and then just go in the bathroom and give yourself an insulin injection. But if you have a pet, you have to stay home. So what about people that get cats because they want to have pets that maybe they don't have to walk twice a day, etc., and now all of a sudden it's diabetic. And they're thinking, this is great, now I have to be home with this cat all the time, which people have work schedules, people have social lives. So we lose these guys because we create a scenario that people can't follow. And I'm just throwing that out there for you because there are going to be different situations that you're going to choose different types of insulins based on what owners' needs are. And we have to think about that, especially with endocrine diseases like diabetes, like Cushing's disease, that require a lot of therapy and monitoring, because some people just can't do it. And we have to say, okay, let's see what you can do, because otherwise you're going to lose the pet anyway. They're going to abandon it or euthanize it. So we're going to talk about a few things that people are are a few things to think about. All right, so hey doc, I can't afford my own meds. How am I going to treat Fluffy? Okay, this is going to be a common one. All right, so in that case, one of the things that I would recommend for that owner is NPH insulin. It's a human recombinant. It's 100 units per mil. It is available without a prescription. It is available, so if owners run out of it on Saturday night, which always happens, they can go to CVS or Walmart and they can get it. It is available as a generic, which is much cheaper than the Novolin or Humulin that works just fine. The problem, there are a couple of problems with this. In dogs, it absolutely is not a once-a-day insulin. It's not a very long-lasting insulin in dogs, but in some dogs you can get away with it. Some dogs you can't. It's not appropriate in cats because it just doesn't last very long in cats. So you can give it to a cat, but you're going to be giving it like 4 times a day. So, but again, it is the cheapest option out there, and if that's the priority for the owner, then I would steer them towards NPH, okay? And again, it's a U100, so you can use the more readily available U100 syringes. All right. Hey doc, I absolutely cannot give injections twice a day. Sorry, I can't do it. I work really long hours. That's just not something I'm gonna do. All right, so in that case, you wouldn't think about NPH because it's gonna be a relatively short-acting insulin. You would think about an insulin that might be longer acting. And 2 that are out there that have been licensed for use once a day in the dog and also, actually my cat's actually on Prozinc once a day. I have a diabetic cat and he's on Prozinc once a day, so you can use it once a day in the cats as well. But Prozinc and Vetselin, you can use once a day. In my hands, Vetselin is not a once a day insulin, but it is licensed to be used that way. But again, these are both veterinary insulins that you can use that are relatively inexpensive. Okay, other ones that you can use that are long-acting insulins, a little bit more expensive, Lantus, Detamir, and Tresiba. Those are, and Toujeo actually too. I have them up here. These are human insulins. Again, maybe your second-tier choices because it's good to use the veterinary insulins if you can, and these would be ones that I would try the veterinary insulins first. All right. Hey doc, nothing's working and I'm getting frustrated. What are you going to go to? So these are what I call rescue insulins. And these would be a couple of them that I would think about. In the dog, I would think about Detamir. That's a really good rescue insulin in the dog. It's reasonably expensive. It's a human insulin, but it works nicely in dogs long term. In cats, Toujeo, which is a U300 glargine. It seems to work a little bit differently than just tripling the glargine dose that the cat is on. It actually is more concentrated and releases more slowly. So Toujeo is actually quite a nice insulin. They're going to be expensive. They're going to come in pens. Okay. Hey doc, I can't see to drop the insulin in the syringe, okay, which happens, okay? So if you had somebody that told you that, then some of the things that you would think about would be using something that came in a pen. And the only veterinary insulin that comes in a pen is Vetselin. Again, it is not highly used, and I don't get it because they're pretty convenient to use. But that is one thing that you could use. And that's probably not the best insulin in a cat. If you had a cat, I might think about using Lantus in a pen. But again, you would think about using something that's available in a pen. Okay. Some new concepts that are out there. I'm going to talk about a few new things. One is in cats, this is just, yes, question.
So I was just wondering, with all these different options, are you still sticking to the same amount of insulin per day and just having to give it in smaller doses?
You are. I use a standard dose, and I'll give that to you. I'm going to give you, well, it's in your PowerPoints that you have. I'm going to give you what I like. It doesn't mean it's what everybody likes. It's not the rule. Dr. Bugbee may pick a different list, and I would believe him more than me. But I'll give you what I like, and I'll give you starting doses. And it doesn't matter what insulin you're using, use the same starting doses. I want you to know that this is a concept that's out there. This is something new. that has just been published, people using 2JO as a basal insulin and then giving NPH as kind of a bolus when the cats eat. This is going to be for a pretty special case. Most cases you would never have to do this. So unless you're going to go into endocrinology, you probably don't need to know about this, but that is something new that is out there. The other thing that you will be using, and it's probably going to, hopefully will be out in 4 years maybe, it takes a while to get things through the FDA, is there is an insulin that you're going to be able to give once a week. And we actually did some of the clinical trials for that here. It's a very exciting insulin that's on the market. It has been bought by a veterinary company, and again, they finished, I think, their preliminary trial, and they're just setting up their pivotal trial to get it through the FDA. But this would be an insulin injection you give once a week, which is going to save so many lives, so many lives. I can't even tell you how many people get frustrated doing insulin, you know, once or twice a day, and now they can do it once a week. Plus it worked really well in the cases that we saw in the hospital that had it. So that's coming along. This is my long-term insulin choices in dogs. This is just what I do. If cost is an issue, I do NPH. Otherwise, I do Prozinc. It's just what I like. And I'll try Prozinc once a day. If you're going to try it once a day, 0.7 units per kilogram is a good starting dose. If you're starting twice a day, then 0.5 unit per kilogram. Then if these don't work, then Lente or Vetselin, or if the owner wants to use that, I certainly will do that. That has a pen if the owner wants a pen. And my rescue insulin in dogs is Dedamir. Anyway, this is just first tier stuff. And this is just my picks, okay? This is not, there's no rule involved here. In cats, I like Prozinc a lot. And again, my cat is on once a day Prozinc, so it'll work SID in some cats. I also like Glargine, and if I can't get anywhere with them, then I'll go to 2JO. The published dose is 1/4 unit per kilogram. That's in the AHA guidelines. I use up to 1/2 twice a day because I like to try to get them into remission. And then 1/2 to 0.7 units per kilogram if you're going to use it once a day. Yeah?
So for TJ, I know you said it's like way more concentrated. So A, would you ever use, so we said it was like a rescue insulin. So would that be your continual choice? Like, I guess I'm confused on like, would you use it only in emergency or rescue or?
Yeah, that's a good question. So when do you pick the rescue insulins? The problem with the rescue insulins is they're expensive. And so if you could get away with something less expensive for the owner, that's helpful. And a lot of times you can. I would say that probably 50 to 60 of the diabetics that you see in practice are going to be pretty straightforward. They're going to come in, you're going to diagnose them, you're going to start them on Vetselin or Prozinc because that's what's licensed for use, or NPH if they really are money restricted, they're going to do fine. It's when you get to the more complicated ones that we start exploring different insulin therapies that we can use. Could you use 2JO as a first line insulin? Absolutely. And if the owner's on 2JO, let's face it, they're going to want to use their own insulin because they can get it for free. So they will be asking you about that, about using it. And you have to say, no, you can't do that, knowing that they're probably going to do it anyway. So, did that answer your question? Okay. All right. So in the last couple of minutes, I just want to talk about some adjunct treatments. One for cats, it's not a drug, but it works like a drug, and that's going to be diet. So a low carbohydrate diet in cats that are diabetic makes a big difference. So cats are pretty carb intolerant, so the low carb diets can make a big difference in cats when you're treating their diabetes mellitus. In dogs, diet is not a game changer like it is in cats. We like to feed them a high insoluble fiber diet, but again, it's not as big of a deal as it is in cats. Cats, a low carb diet will really help diabetics. Now, if you have a cat that's in renal failure, well, you can't do a whole lot about renal failure, right? So if you have a cat like that, you're probably going to want to feed for the renal failure, but if you have a choice about a diet to use in a cat, a low carb diet will really help. Usually we feed them twice a day, give them a little bit to see if they're going to eat it. Usually what I do is I put the food down. When they start eating them, I give them the insulin injection as they're eating, because then they don't even notice that they're getting it, and that way you just make sure that they're eating. Okay, There is an oral hypoglycemic agent out on the market called glipizide. This is a very old drug. It doesn't work for the most part. And it's a sulfonylurea. It was out there when I was doing my residency, and we had to try to use it, and it never worked. And then there was a lot of data that showed that maybe it might make things worse in cats. This would be a drug that you would use with cats because they have type 2 diabetes mellitus, where they actually still make insulin. And I'm mentioning this to you because it may show up on a NAVLE exam because it is an oral drug that you can give. It is not, by the time you guys get into practice, there are going to be better alternatives out there for you in cats. But this may show up, okay? Some of the new things on the market are incretins. And this is just, these are, work on this is going to be forthcoming. Probably within a year, there's going to be a ton more stuff out on it. These are GI hormones. They work like a sulfonylurea does in that they increase insulin production, which means you have to have beta cells to actually be able to make insulin to have this work, which is why we use it in cats. The other nice thing is it may have some protective effect in cats on their own pancreatic beta cells. So, so that may help them as well. It also promotes satiety and it decreases gastric emptying. So there may be a use for it in dogs as well, but it's been mostly explored in cats. It may work also by suppressing glucagon. But anyway, these are new. The one that's being used in cats is exenatide, ER. There are some published papers that have come out of that. They've used it with glargine to try to induce remission. It is also an injectable, which is a problem for people that don't like giving an injectable medicine. And you have to give it for like 6 weeks. So I want you to know it's out there. You don't have to memorize how to use it, but it's out there, and some of the protocols will probably be more defined as you go through school. The other drug that I want to tell you about, and again, I know about this because we did the clinical trials, some of the clinical trials here at the University of Georgia. And this has been bought by a drug company as well. It is an SGLT2 inhibitor. It is going to be an oral hypoglycemic medicine for cats. It is in final clinical trial right now to get approved by the FDA. I suspect it will be by the time you graduate. So again, the landscape in diabetes care in cats especially is going to really revolutionarily change, and actually in dogs as well. So in the next 5 years, the landscape of these drugs is going to totally change. This is what we have available now. This is what you need to know about now. And in terms of cost, I think that the drugs that I know of that are coming out are going to be reasonable cost. They're going to be pretty cost effective because people don't make stuff for the veterinary market unless it's pretty cost effective. Yes?
The GLP incretins, are those kind of similar to like metformin and humans?
So metformin is another sulfonylurea type drug, so it actually helps increase insulin secretion as well. So it actually works on exocytosis mechanisms as a little bit different than the sulfonylureas do. But it is similar to that. This works a little bit differently. Part of the problem, so you'd use this for cats because you got to be able to make your own insulin to begin with. And most dogs, like their pancreas is destroyed. One of the things, and actually a lot of the work was done here before I even got here, showed that when you make those cells work really hard in cats, you actually increase amyloid deposition in those cells. So it doesn't really work and it never really worked very well. So we don't use metformin a lot, even though theoretically you should be able to. The SGLT2 inhibitors are used in human medicine, and they're a glucose-lowering drug, and that seems to work pretty well in cats, at least from the clinical trials we did here. And that was a pretty big one. So I think that that's going to be out. They've got to be at least a couple of years into this. So that should be out by the time you graduate. And that is just a hypoglycemic agent. They use them in people as well, but they seem to work nicely in cats. I feel like I threw an incredible amount of information at you, because there is a lot going on in diabetes right now. I promise that on your test questions, I will give you sort of a study thing, because otherwise you're going to be reading and trying to figure out what the hell does she want us to know for this test. I'll do this today. I'll put a little study guide up on ELC for you about this lecture so you know what you need to concentrate on. Most of this I will hope that you keep, and when you get into clinics next year, it'll be a reference for you on how to use some of these drugs, etc. But I'll be asking you very basic questions like, do you pick an IV insulin like regular insulin to treat a diabetic ketoacidotic, stuff like that. So I'll put a little study guide in there for you on this lecture because this is, I know there's a lot of information, but I wanted you to know about it because I want you to know what's happening and what's out there in the market. So I will do that today, and I don't know how many questions Dr. Wagner is going to have us have per lecture. It'll probably be similar to last year, but again, I'll give you some examples about what that will look like so you don't have to worry about going through all this stuff. All right, any questions, let me know. This is my last day with y'all, so have a wonderful, wonderful rest of the year. And the one thing that I can tell you is second year will end. It will end. So thank you for giving me the honor of getting a chance to teach y'all again, and I wish you the very, very best as you go through this year. So, thanks. Hey.
I have a quick question.
You bet. I bet you do. This was so confusing.
It's more legal. We learned in some other classes that you can only use extra label drugs. Well, you can't use a drug extra label if there's a veterinary approved alternative, like justified by cost. So, have you heard that? Or is that like a gray rule? Because I was wondering about using NPH instead of Prozac or Vetsolin
you absolutely can.
for the use of cost.
Yes,
Okay.
you absolutely can. And in veterinary medicine, we can use drugs off label.
Yeah, I know.
It's only in Europe that you can't.
Okay, someone taught us, and I can't remember who. They said that cost is not an acceptable reason to use the drug off-label if there's an on-label option. Does that make sense?
Yes, and that is an opinion. That's not law.
Okay, thank
That
you
is
for
an
clearing that
opinion.
out
It
because
is
I was
not
like,
law.
that wouldn't make sense here. So
No, it is not law. Now,
gotcha.
having said
That's a big distinction. Yeah.
could somebody sue you? Potentially, yes, they could.
But you could
Has
have them
not
sign
happened.
something beforehand.
No, we never do. I use NPH all the time. It's
Okay.
cheaper, and no one has been sued yet. It could happen,
Yeah.
but that's an opinion. That's not law.
Gotcha.
'Cause
Thank you.
Now, if you lived in Europe, you would have to use a veterinary product first,
Okay.
and that is a law. But here it's not. You can use stuff off label, at least for right now. You can.
Thanks for
So-
clearing that up
Oh
for
yeah,
me.
yeah, of course, of course.
Hi.
Hey.
So sorry.
No. This was confusing. I changed it this year because there's just so much going on, and then I'm giving this lecture. And it's like, oh my god, I probably confused the crap out of them.
Okay, I didn't want to re-ask and take everyone's time. So when we say rescue dose, are we saying rescue emergency, or are we saying
I'm sorry, I used that badly. Rescue in my mind means nothing else works. Like
Okay.
I can't get.
okay,
Like
that makes sense.
I've got a cat, and I just can't get that stupid cat under control.
So then we just give them a whopping dose forever.
Or I will go to TJO in that cat because I know it's probably going to work better
Okay.
and longer. Yeah, that's what I
then-
meant by rescue.
Okay, that makes perfect sense. And then with the oral hypoglycemics and their use in cats, you said that it increases insulin secretion.
So what it does is, the way a lot of the hypoglycemics work is metformin is an exocytosis inducer, and that's how insulin gets out of the pancreas, and also the sulfonylureas increase insulin secretion as well. And so the way that works is it takes your beta cell that's kind of not being very efficient, makes it secrete more insulin. The problem in cats is that the beta cells don't want to work very hard, and when you make them do that, it actually makes them sicker. You get more inflammation, it lays down more amyloid, and that's different than what happens in people, which is why those growth classes don't work very well on
So if we're
cats.
saying that cats more so get type 2, where they're just producing way too much insulin, they're resistant, why is that helpful to
Oh, that's a great question. So what happens in type 2 diabetes is